Hey guys, this is Dr. Aman Setiya, your medicine faculty at LN Next. So today we'll discuss our discussion of grant test. So I hope your questions are correct. So again, medicine is like a big subject. So I hope we'll solve these questions together. Let's see. 45-year-old female comes to you with report of hemogram. So like hemogram, in that hemogram, hemoglobin is 10. Reticulocyte count is 3%. Peripheral blood smear is not showing any polychromasia, means there is no finding in peripheral smear. So what is corrected reticulocyte count? So this is like a simple formula based question that they have asked. So understand this CRC. CRC means corrected reticulocyte count. How we calculate this? Understand this. Whatever reticulocyte count given in percentage divided by I can say this is like multiplied by patient hematocrit. So whatever is patient hematocrit upon desired hematocrit means a normal hematocrit. So I can say normal hematocrit. So understand this. Hematocrit is hematocrit. How we calculate? Hematocrit is 3 times of hemoglobin, means hemoglobin multiplied by 3. So now if I apply these things in the question, so understand reticulocyte count given is 3%. Patient hematocrit, patient means hemoglobin into 3, so 10. 10 into 3, that is 30. Divided by normal hemoglobin, the desired is 15. So we assume like normal hematocrit is at 45. So this is like a data that we use in practice. So 30. So let me write like this simple way. 10 into 30. So normal hemoglobin 10 into 3. Sorry. Divided by 15 into 3. So you will see the value. This will come like 3 into 30 divided by 45. 30 divided by 45. So this, if you multiply this, this will come 90 divided by 45. That means the corrected reticulocyte count will come 2%. So answer for this question will be 2%. Simple. So this is how we can calculate corrected reticulocyte count. Okay, coming to next question. Let us read the question first. 40-year-old. So first in the MCQ is the age itself. Present to emergency department with acute chest pain and dyspnea. So ECG having ST elevation MI. So it's a clear cut. They have given you a case of ST elevation MI. Patient has systolic blood pressure of 80 mmHg with features of pulmonary edema. Means patient is having MI as well as heart failure. He undergoes an emergency balloon angioplasty with inotropic support for low BP. So basically it is like intra-aortic balloon pulsation. What we call this? We call this intra-aortic balloon pulsation, that is to increase the BP. Post-procedure he has blood pressure of 70 and is continued on 2 inotropes. He complained of chest pain in post-operative room. Which of these antigens can be given to the patient? Now understand this, whenever you are giving intra-aortic balloon pulsation to patient, so we will see like a BP will increase automatically. So here whenever you use, suppose if you are giving nitroglycerin or you are using CCBs like diltiazem, or we are using beta blockers like metoprolol. So all these drugs will cause further decline in BPs. That's why we should avoid them. So answer for this question is none. Suppose in this question, like if I add one more choice, suppose like I can give you one more option, like if I would like to add here celiprolol or bisoprolol or amlodipine, then I will choose the answer as diltiazem, because diltiazem will cause less reduction in BP. So correct answer, remember, all these anti-anginal drugs are avoided, because these anti-anginal drugs, what they can cause? They can reduce further BP when patient is already on inotropic support. Then there is no point of using an inotropic agent. That's very, very important. Okay, let us see question number 3. All of the following are primary vasculitis syndrome except. So this is, I think I already discussed this many times. So granulomatous with polyangiitis, it's a primary vasculitis. IgA vasculitis is a primary vasculitis. Giant cell arteritis is a primary vasculitis. Drug induced is always secondary. So these 3 are example of primary vasculitis. What are others? So remember, whatever we study in this topic of vasculitis, like I can say Takayasus arteritis, temporal arteritis. Then we have Churg-Strauss syndrome, microscopic polyangiitis, vaginous granulomatosis, polyarteritis nodosa, Kawasaki. All these are primary vasculitis. Drug-induced vasculitis is always secondary. Is it clear? So that's something which you have to remember. Okay, coming to next question. Following investigation finding is a hallmark in patient with kidney disease that begins primarily with glomerular dysfunction. So whenever there is a problem in the glomerulus, remember the first finding what we say is microalbuminuria. Now see, electrolyte disorder or disorder of dilution and concentration of urine, that is a function of tubular damage. Means that is basically a electrolyte balance, and I can say dilution and concentration, that's the job of tubules. So this will be affected when tubules are damaged. Is it clear? So these are due to tubular dysfunction or tubular damage. So what we see, the first finding is that we see is microalbuminuria, that is suggestive of glomerular damage. Very, very important. So I hope the answer is clear. Glomerular damage, the marker, the finding is albuminuria. Okay, coming to next question. 26-year-old female comes to the clinic with complaint of mouth ulcers. There could be mouth ulcers, so that can be aphthous ulcers. Increased sensitivity to light, that is photosensitivity. A rash appearing over the cheek, face while spraying the area over around the corners, the nose and mouth. Means the area around the corners of the nose and mouth, they are spared. So that is the classical rash that we see in SLE. We call it butterfly rash. So clear-cut answer for this question will be SLE. So this is like you can see like Sturge-Weber syndrome disease that we see in children. Dermatitis can occur any part, and psoriasis can affect any part. So remember the answer for this question is the classical rash that we see in SLE. So this is that classical rash that we see in a patient of SLE. Okay, coming to next question, that is which type of sensation is affected on the same side. So they are asking you sensation affected on the same side as that of lesion in Brown-Séquard syndrome. So understand this, in Brown-Séquard syndrome, what you will see like a loss of proprioception on the same side, right? And what else you will notice? You will notice there will be like on the opposite side, you will see there will be loss of pain and temperature. Pain, temperature, this will be on the opposite side. So again, like this is a straightforward question. This has been asked a lot of time. That is loss of proprioception or a sense of body on the same side. A 35-year-old individual is brought to the emergency room. So first hint in the MCQ is the age itself. After collapsing at a restaurant, he has pulse rate of 120, means tachycardia, respiratory of 30, means tachypnea, and a BP of 90/60, means hypotension. So you can clearly see like patients having tachycardia, tachypnea, and hypotension. So patient is in shock. Person breathing is difficult, but he can speak. He is experiencing widespread bronchospasm and has continuous cough. So it is not pulmonary embolism. Just by looking at the cough, we cannot say this, right? Because most of the pulmonary embolism, they are asymptomatic because they are small. It is not a drug overdose because the findings which are telling you it's a shock means there is tachycardia, there is tachypnea, and the patient is having hypotension. That's very, very important. So it is not due to aspiration, it is not due to drug overdose, it is anaphylactic shock. Is it clear? So this is like a candidate who is having widespread bronchospasm, so you have to give him adrenaline at the earliest. That is the treatment of anaphylactic shock. 38-year-old man arrived at the emergency department with symptom of fever, nausea, vomiting. He described experiencing intense and sharp abdominal pain. While lying flat on the bed, he shows reluctance to move and exhibit shallow breathing. Means patient is having that intense pain, like he don't want to move his body, right? The patient posture and behavior are most likely associated with which of the following condition. So understand this, it's an abdominal pain, so there is no point of having meningitis as diagnosis. Renal colic pain will be intense, but this will have movement towards the tip of the penis, sometime like in female patient towards the vulva. That is not mentioned. So it is the hint in the MCQ is like you will see when lying on flat, even on lying on flat on bed, he don't want to move because he is having intense pain. So that is where we see this type of pain. If I say colic pain, I told you this will move to penis tip. Then I can say pancreatitis pain, this will radiate to back. This is the case of peritonitis. So pain is very intense, like sometime. So what else? Other feature you will see. So that you will see in this patient, the patient will have intense pain. So patient will barely move from the bed. And when you touch the patient, there will be, even on touching the abdomen, he will shout with pain. And sometimes what we see rebound tenderness. You will see rebound tenderness. We call this as Blumberg's sign. And what else is important, like when you do the x-ray, so generally how we make a diagnosis, either like an x-ray abdomen in erect posture, if you do, you will see gas under diaphragm. Gas under diaphragm. So these are findings you will see in a patient with acute peritonitis. Okay, let's see another question. A 62-year-old female, so age is itself as a hint, old female, admitted to hospital with symptom of nausea, vomiting, headache and confusion, without signs of volume depletion or renal dysfunction. So diagnosis is given SIADH. I was about to say this. Following finding is not expected. So understand this. In SIADH, first thing is to make a diagnosis of SIADH, there should not be any history of nephrotoxic drug exposure. There should not be a prior kidney damage. There should not be prior history of renal dysfunction. So in SIADH, what I can see, understand this, whenever you have a patient of SIADH, you will see patient will have euvolemics. That's why it is written, no sign of volume depletion. So there will be euvolemic hyponatremia. Euvolemic hyponatremia. Sodium value is less. So when sodium is less, so understand this, most of these patients, they will have a normal BP. And the second important finding you will see in a patient of SIADH is, like you will see these patients, they will have a very less urine output. So there will be decrease in urine output. And that urine output, this urine will be concentrated urine with increased urine osmolality. So this will be a concentrated urine with increased urine osmolality. So urinary sodium will increase. Simple. Now try to understand this. BP can be normal. Yes, it can be. Low uric acid. Uric acid level can also be low in a patient of SIADH. But in most patients, you will see it is in normal range. Normal serum urea and creatinine. Kidney function should be normal. So these three are present. That is actually seen. Hypernatremia is not seen. What we see in SIADH, you will see hyponatremia. It's the classical example of euvolemic hyponatremia. Very, very important. So how you will manage this patient? So remember, for treatment, what we give Vaptans. We give Vaptans. Okay, coming to next condition, patient came to emergency with palpitation and extreme sweating. Palpitation, so this is one hint, and extreme sweating. He also complained of pain in front of the neck. So he is having pain here, which radiate to ear. There is tachycardia, 123. Thyroid function test reveals thyrotoxicosis. So it's the case of thyrotoxicosis. Radioactive iodine uptake test shows a low uptake. Now, which condition is most likely responsible for thyrotoxicosis in this case? Now, try to understand this. The question is a little difficult, so just try to understand this question. If you see this question, the hint is radioactive iodine uptake. We call this RIO. This radioactive uptake is increased whenever your gland is working more. So what are the conditions where your gland is working more? So understand this, it can be like equally increased in both the gland in case of grave disease. So this is what I know about this disease. In grave disease, you will see a bilateral equal uptake. Then this can be increased and it will be more centralized whenever there is a toxic adenoma. In case of toxic adenoma, you will see it's more at the center. And you will see, like whenever the patient is having, I can say, toxic multinodular goiter. In that case, you will see a random uptake. This RAIU scan or radioactive iodine uptake scan, this will be decreased whenever your body is having hypothyroidism. So which condition can cause hypothyroidism? Understand this, it can be due to thyroiditis. Now see, TSH producing pituitary adenoma is also a condition. There is more TSH. More TSH means that will give feedback to thyroid, so there will be more T3, T4. So again, thyroid functions or radioactive iodine scan will be more. So thyroid can be stimulated more, so it will cause more uptake, more increase in uptake. And this uptake is almost like grave disease. So only condition here, as per the list, you can notice, like only condition where you can see radioactive iodine uptake is decreased, that is your thyroiditis. So what will be the answer for this question? In this question, the answer will be subacute thyroiditis, because here you can see iodine uptake will be decreased, because whenever there is inflammation in the gland, the iodine uptake will be decreased. So answer will be C. Okay guys, coming to this question to understand this, which of the following is not typically seen in individuals with Conn syndrome. Conn syndrome, what you will notice, it is due to, it is primary hyperaldosteronism. So there is more aldosterone. There is more aldosterone means this will lead to, more aldosterone means it will lead to, I can say, sodium and water retention. This will be more. And in exchange of potassium and H positive ion loss. So potassium will be less and H positive ion will be less. So understand this. So sodium is more. So unlikely, you can see normal sodium is not seen. It is not typically seen. There is hypernatremia. So that's why sodium is generally increased. Then we can see water is increased, but later on due to diuresis, this will become normal. So that is even not even the option. There is less potassium. There is less, or I can say loss of H positive, so that will lead to metabolic alkalosis, and hypokalemia will produce muscle cramp. So that is why the answer for this question will be normal serum sodium. Is it clear? So understand this question, it's very important. So there is more sodium, there is less potassium, and less potassium will produce muscle cramp, and there is loss of H positive ion that will lead to metabolic alkalosis. Loss of H positive ion will lead to metabolic alkalosis. So that is something which you have to remember. Okay, sepsis patient, the main modality of treatments are all. So suppose you are having a patient with sepsis. So sepsis, definitely you will give antibiotic. Except, question they're asking, except. In sepsis, suppose patient is like dehydrated, is admitted in ICU. So we have to give IV fluid. IV fluids are given. In sepsis, whenever patient is having sepsis, the sepsis converted to septic shock, we have to give vasopressor. There is no role of steroid. I repeat, there is no role of steroid. So they ask you like, we have a non-specific marker for sepsis. So they can ask you a question in exam. So what is a non-specific marker for sepsis that we use in practice? We call it procalcitonin. Procalcitonin. Then other like your ESR, CRP, ferritin, these are also markers for sepsis. But what MCQ you have to remember is procalcitonin. Okay, which factor most frequently lead to acute hepatic liver failure or acute hepatic failure? So question is like, what is most common cause of acute liver failure? So remember, most common cause of acute liver failure is toxin. Toxin may on drugs, means it could be due to certain toxins, like suppose a person is coming to you after harpic poisoning, or person have taken overdose of any drug. That's most common. If I ask you after this, the most common cause will be hepatitis D. Hepatitis D, which can lead to fulminant hepatic failure. So excess and prolonged alcohol consumption. So understand this, alcohol is although a mitochondrial poison, this will damage the hepatocyte mitochondria, but it's not a common cause of acute liver failure. Infection with hepatitis A. Hepatitis A is not a leading cause. Liver damage by drugs. Autoimmune hepatitis is very rare cause. Is it clear? So other can cause a generally chronic disease. So like toxins and drugs. We also use a term called DILI. DILI means drug-induced liver injury. So remember, drug or toxin-induced liver injury, that's most common cause of acute liver failure. Okay, after undergoing a thyroidectomy, a 45-year-old patient experiences symptom associated with damage to parathyroid gland. Means you are doing thyroidectomy, you have accidentally also removed parathyroid. Following symptom of finding will be anticipated in this case. So basically, a patient is developing hypoparathyroidism. Right? So understand this. What finding you will be anticipating that they're asking. So because of low PTH, understand this patient will develop low calcium. There will be low calcium. So patient will develop hypocalcemia. When there is hypocalcemia, what you will notice, patient can develop tetany. So there will be like tetanic contraction. In that contraction, you can see reflexes are enhanced. So what we see, we call this, there will be exaggerated reflex. Is it clear? Urine production is not increased. In fact, I can say this will be seen whenever there is a brain surgery, not in thyroid surgery. Difficulty passing stool is usually not seen. Excessive sleepiness is not seen. So what is the answer? Exaggerated reflex. Following is a marker of inflammatory bowel disease which help to rule out irritable bowel syndrome. So how we can differentiate So we can differentiate this with the help of fecal lactoferrin. Fecal fat, fecal chymotrypsin, fecal trypsin, these are used for malabsorption syndrome. But remember, fecal lactoferrin is the one that is used to differentiate IBD. So let me write this. It is used to differentiate IBD from IBS, irritable bowel syndrome. Simple. Okay, now you can see the ECG. You can first in this ECG, what you can notice? You can notice like this is a broad QRS. So when I see the question broad QRS, it means these two are ruled out. Simple. So you can see broad QRS, so these two are ruled out. Then if you see this RR interval, you can see these are regular. Regular RR interval, it means that this is ventricular tachycardia. In ventricular fibrillation, you will see this type of pattern, right? So that is an irregular R interval. So regular RR interval, broad QRS, that is suggestive of VT, ventricular tachycardia. Other than this, you can see sometimes capture beat, fusion beat. These are also ventricular tachycardia. Following statement is not true regarding the differential diagnosis of 11-year-old child present. Very interesting question. You can see not true regarding that differential 11-year-old child with failure to thrive and metabolic acidosis with increased NN gap. So you should know what are the causes of increased NN gap. So you can remember by mnemonic cult. Cult means it can occur due to ketosis, due to uremia, right? Then you can see due to lactic acidosis and due to some toxin. So these are the causes of increase NN gap. And remember, normal NN gap, we call this nagma. This is called hagma. Normal NN gap you will see in a patient with diarrhea, RTA and ureterosigmoidoscopy. So let us see this option one by one. If you see like RTA is a condition where always you will see normal NN gap. And if you ask me renal failure, so you can see uremia means it could be AKI or CKD that will have increase in NN gap. Diabetes mellitus can convert into DKA that can have increase in NN gap. Inborn error of metabolism, so many inborn errors of metabolism, they can produce ketosis or lactic acidosis and that will lead to again increase. So understand this RTA, whether it is any type of like type 1, type 2, type 4, all these RTA will have NAGMA, that is normal NN gap, metabolic acidosis, very, very important. Okay, coming to this, which test is useful for quickly diagnosing cryptococcal meningitis in a 30-year-old male patient with AIDS? For quick diagnosis, presenting with fever, vomiting and meningismus. CSF culture is never quick. Culture will take time. Two options are ruled out. For quick diagnosis, understand even India preparation is not used. We have blood lateral flow assay. So this is like what we call this lateral flow assay. That's currently like a test which we use a lot in practice to make a quick diagnosis of cryptococcus. Very, very important. Predominant type of non-Hodgkin lymphoma found in India. So understand this, in India or in any country, I told you like we have follicular cell lymphoma, Burkitt lymphoma, diffuse large B-cell lymphoma, marginal zone, maltoma, then what we have mantle cell leukemia or mantle cell lymphoma, hairy cell leukemia. So all these are non-Hodgkin. Out of this, non-Hodgkin lymphoma, they generally will have less sign and symptoms. So by the time it is diagnosed, this already reaches into diffuse stage. That's called DLBCL. So most common type, I can say, most common type diagnosed will be the better term. And worst prognosis is same, that is diffuse large B-cell lymphoma. That's something which you have to remember. So most common type. Marginal zone lymphoma is something that is related with inflammation. So they can give you like inflammation associated lymphoma, that will be marginal zone. Burkitt lymphoma, this is one. This is after diffuse large B-cell lymphoma, it is second dangerous tumor. These two actually are the tumor which will have higher mitotic index. So Burkitt lymphoma, I can say this is seen in African children, but again not that common. Follicular cell lymphoma, this is due to translocation 14-18 due to overexpression of BCL2 gene. That is something which you have to remember. Here you will see CMYC gene and translocation will be translocation 840. Okay, so in this questions, let us see a 35-year-old Presented to outpatient department, complaint of persistent excessive sleepiness and lethargy. Clinical images reveal characteristic finding. Abdominal examination indicate no presence of free fluid, and the liver and spleen were non-palpable. Liver and spleens are not palpable means you can see like liver is squeezed. There is a shrunken liver. So shrunken liver, this is the hint. Patient report history of irregular alcohol consumption. So I can see like you can see some sort of clubbing here. You can see like there is a yellowness in the skin texture. You can see yellowness in the eyes. Then you can see like these are contracture formation. So it's a case of CLD. CLD means chronic liver disease, that is liver cirrhosis due to alcohol. Hepatolenticular degeneration is Wilson disease. So whenever we see like image of eye, we try to mark the answer Wilson disease. Remember, nothing. Let me zoom this. Can you see any Wilson disease? No. But can you see any Desmond membrane ring? KF ring? No. Can you see sunflower cataract? No. So it is not hepatolenticular degeneration. In portal hypertension, you will be getting some signs like there will be variceal bleed, right? There will be hemorrhoid. So that's not seen. Budd-Chiari syndrome, again, you will see some findings like there will be jaundice. There can be jaundice, but this unlikely you will see contracture. So that is the answer. There is classical history is given alcohol, so it will be alcoholic cirrhosis. Which of the following symptom is not typically observed in patient with malabsorption? So understand this. With any malabsorption syndrome, you will see patient will have abdominal pain because things are not getting digested. So there is a gut rule. If gut is not digesting something, it is not properly absorbing something, gut will throw it away. It can throw it away in the form of vomiting, or it can throw it away in the form of diarrhea. Or patient can develop steatorrhea. Steatorrhea means fatty stool. And why we take nutrition? We take nutrition to get some energy, we get to get those nutrition like micronutrients, vitamins. So that micronutrient deficiency will occur. So these are common symptoms that we see in any malabsorption. So steatorrhea is defined when stool fat content is more than 7 gram%, so that stool fat is more. So in malabsorption, you will see excessive stool fat, that's true. Anemia, you will see yes, because there is deficiency of iron, there is deficiency of folic acid, deficiency of B12. So that's why we can see anemia. Abdominal pain is seen, yes. Difficulty with bowel movement is usually not seen. In fact, patient have diarrhea, so diarrhea bowel movement will be more. Okay, what are the key indicators used for classification of CKD? So remember, for CKD, we have classification like how we classify CKD based on GFR. So GFR is given somewhere, yes, eGFR is given. And creatinine, no. Creatinine and urine output, they are used for AKI. Is it clear? Serum albumin and creatinine we use for HRS. Serum urea creatinine, where we use just urea creatinine, and urine output we use for AKI. For CKD, we use eGFR and we use urine albumin excretion. We call this AEC, albumin excretion rate, AER, albumin excretion rate. So that is a parameter that we use to grade CKD. Okay, then we have a 45-year-old obese hypertensive patient present with symptom of ataxia and incoordination. Likely cause of the symptom is the involvement of which among the following? So understand this, whenever you see like a patient having this finding, then this is generally due to involvement of superior cerebellar artery. Ataxia and incoordination, superior cerebellar artery. Okay, then what we have a patient with known case of COPD experience an acute exacerbation of symptom. During examination, patient is conscious and alert with a pulse rate of 110. Bilateral wheezing is observed. Following statement is not true. So it is like I can say this is a case of asthma, or I can say this is an asthma with impending respiratory failure. Very, very important. So whenever you see a case of asthma with impending respiratory failure, what we should do? Not true, they are asking. Permissible hypercapnia is allowed. You can allow this. Yes, this is a true statement. IV steroid should be administered. Yes, it's asthma where patient can die. Non-invasive ventilation is contraindicated. No. It is actually, we will start with this. Straight away, we should start with this. So this is a false statement. Inhalation with salbutamol should be done. Yeah, definitely yes. So whatever possible things are there, that should be done. Even we can give MgSO4, we can give non-invasive ventilation, not improved, then we should do invasive ventilation. So everything should be done. Is it clear? So it's a case of COPD exacerbation. A 45-year-old male visited to hospital for a routine anti-HBS investigation, which turned out to be positive. Means anti-HBS is positive. Anti-HBS positive, it means it's the patient who is have either cured or having immunity. Further investigation revealed a positive anti-HBC result. Anti-HBC positive. Patient abdominal ultrasound and liver function test normal finding. What are the diagnosis? Is it acute infection? No. In acute infection, IgM should be positive. There should be a marker like hepatitis B surface antigen should be positive, but instead antibody is positive. Immune due to hepatitis B vaccination, here only I can say if it is vaccinated, only this will be positive. Anti-HBS, anti-HBC will not be positive. Resolved infection, no, it is immune due to natural infection. So answer for this question will be B, immune due to natural infection. In a 17-year-old male patient who is brought to the hospital following trauma and is unconscious requiring immediate intubation, the standard method used to open the airway is being asked. It has been determined that cervical spine precautions are necessary for this patient. Following technique is commonly employed to open the airways in this situation. Sideward movement of tongue is not recommended. Forward displacement of jaw, no, not recommended. So what we do? Tilt the head back and lifting the chin. This is the thing that we observe. Lifting the neck from the posterior aspect is not done. So what is done? Tilting the head back and lifting the chin. This is this technique that is employed to open the airway. Okay, what you can see in this, you can notice like there is little cardiomegaly you can see, then you can notice there will be a prominent JVP wave if you see like V wave A, X, Y. So prominent Y descent is there. Where we see prominent Y, PATEX, remember? Pericarditis will have prominent Y descent. I know many of you are answering this is to be cardiac tamponade. So understand this, in cardiac tamponade, what you will see? You will see in cardiac tamponade, you will notice there will be prominent X descent. It is not diffusion. It is not a case of DCMP because you will see cardiomegaly here. And what happens is whenever you see like Kussmaul sign is seen, in Kussmaul sign is more classical for constructive pericarditis. That's very, very important. Most common cause of renal failure in patient with multiple myeloma. So multiple myeloma patient can develop kidney failure due to all of these causes. But what is more common? It can occur due to light chain deposition, it can occur due to amyloidosis, due to hypercalcemia, due to light chain, cast nephropathy. But the most common cause is hypercalcemia, very, very important. So multiple myeloma can develop renal failure even due to many others, due to anemia of Conn disease. They can develop, I can say, renal failure due to many reasons. There are multiple reasons, more than I can say 8 reasons are there. But the most common cause will be hypercalcemia. So they can also develop due to amyloid deposition, then I can say due to cast nephropathy, due to hypercalcemia, due to Mans-Jones protein, due to hyperviscosity. There are multiple reasons. 60-year-old male present to OPD with complaint of left-sided chest pain, cough with red color sputum and high-grade fever for last 3 days. He is on regular medication for the treatment of diabetes mellitus. HbA1c 6.8 means fairly controlled. Respiratory rate is 28, SpO is 93, BP is 120, 56. There are bronchial breath sound in the left and capillary area. So basically it's a case of CAP because patient is coming into OPD. So it's a case of coming to acquired pneumonia and they're asking you what is the most common cause. Most common cause will be Streptococcus pneumoniae. Is it clear? It's a case of CAP. If it could be hospitalized patient, then we could have thought of Staph aureus, but it is CAP. An 18-year-old tall young boy present to emergency room with complaint of acute onset shortness of breath and right-sided pain. He is found to have right-sided pneumothorax. He has a similar episode of right-sided 6 months back. Similar history he had requiring intercostal chest drain insertion. Pleurodesis is planned after intercostal chest drain insertion to prevent a recurrence. So understand this, what we plan, we always do pleurodesis to so that this will not occur again and again. Following agent is agent of choice. So we can use bleomycin, we can use tetracycline, we can use fluorouracil also, but the preferred of all is a talc slurry because this will not produce any sort of idiosyncratic reaction or allergies that we can see with bleomycin or any other drugs. So talc slurry is preferred agent for pleurodesis. 7-year-old child present with rash on the lower limb, abdominal and joint pain. Child, rash on lower limb, abdomen, joint pain. So yellow fever, no. Dengue, no. SLE, no. It is HSP. Abdomen, thigh, legs, buttocks, rash, young child, it is always HSP, Henoch-Schönlein purpura. Tall T waves with wide QRS, prolonged PR. So tall T wave where we see, we call this hyperacute T wave, what we call this tall tented-like T wave we see in a patient of hyperkalemia. A 40-year-old female cook present to emergency with sudden onset dyspnea. She is tachypnea, tachycardic and has tender calf and thigh-on palpation. Chest X-ray and BP are normal. a provisional diagnosis of pulmonary embolism is made. So you can see there is tenderness in the calf or thigh on palpation. So it could be a case of pulmonary embolism. To confirm this, what is investigation of choice they are asking? So best test will be angiography. Angiography, we need to search CTPA. It's computerized tomographic pulmonary angiography. So the CTPA is nothing else angiography. So investigation of choice, our gold standard, I can say, that is angiography. So what angiography we use? CTPA. The term is now CTPA. So you can use different, but actually it is same, it's angiographies. So this is about the discussion that we are discussing. Again, the questions are pretty simple. I hope you enjoyed the session. Thank you so much. Keep working hard. Remember, you can, you will. Bye-bye.